Good afternoon, everybody. Today we will discussion is on house systemide sublingual tablet in allergic rhinitis and allergic asthma. Is it going to change allergy practice? Friends, ladies and gentlemen, my gratitudes to the organizing chairman, Dr. Krishan Chug, as well as the organizing secretary, Dr. Talwar, for giving me opportunity to share my thoughts on this subject. This tablet house systemide slit sublingual immunotherapy has recently launched by Dr. Reddy in the name of the SENSIMUNE, indicated in a house systemide-driven rhinitis and asthma. In a GINA guidelines, step 1, 2, 3, and 4 as a add-on therapy. As long as FE1 force expiratory volume in 1 second is more than 70%, and there is no exacerbation for the last 3 months. Friends, allergen immunotherapy is evolving. Everything is evolving in this universe. So the evolution in the medicine, so is the evolution is the allergen immunotherapy. Started way back in 1911, subcutaneous immunotherapy, and 1986, the sublingual immunotherapy. In 2025, there is a sea change. It is a personalized, individualized, customized precision medicine. From clinical experience in 1911, now it has become the clinical evidence-based medicine based on the RCT, the randomized control trial, as well as the real-world evidence. This is the first paper published in Lancet in 1910, giving the protocol of allergen immunotherapy as a build-up dose and then the maintenance dose. What changes occurred today? Initially, it was the unstandardized crude extracts being used. Most of the patients, they were getting adverse reactions due to that. Now at present, we are using the standardized product formulation, where there is a decrease in the allergenicity, but maintaining the immunogenicity along the extract with the adjuvant allergoid or with or without biological. The second change is there. Now we are having a genuine selective allergens which is responsible for the disease eliciting. What causes the inflammation? So-called the major allergens. Not we are giving the intermediate allergen or the minor allergens in our allergen immunotherapy. The third change is there. The mode of immunotherapy has changed markedly from subcutaneous immunotherapy to the sublingual immunotherapy. It is to be given with a standardized product formulation in a monosensitized patients as well as in monoallergic patients, while subcutaneous immunotherapy can be given in a polysensitized or a polyallergic patients. Another change is there. What are the selective, judicious selection of the patients? Can we give allergen immunotherapy in a pre-modeling or in a stage of the pro-pre-modeling or in a stage of the remodeling? In a pre-modeling, asymptomatic patient but sensitized belongs to the high-risk family. Is there evidence that the allergen immunotherapy is effective? At present, there is poor evidence that it reduces the risk of developing new onset asthma. In contrast, in a secondary prevention, in a case of the seasonal allergic rhinoconjunctivitis, in a seasonal allergic asthma, there is a hard evidence that it prevents the airway remodeling, it reduces the airway inflammation, and at the same time it has got a sustained efficacy, long-lasting effect, even after discontinuation of the allergen immunotherapy. So this is the window of opportunity to start allergen immunotherapy. But in case of the third, where the remodeling has already occurred, whether immunotherapy is effective is still a low evidence. But with the advent of the biological, there are certain components in the remodeling which are reversible, may induce a steroid-sparing effect or decrease the intensity and the severity of the symptom. So, ladies and gentlemen, allergen immunotherapy is a complex journey. It starts from the genuine selection of the patients, the right patients, right allergen, right product formulation to achieve the target. It is a 3 years journey, and during that period you have to look for the adverse events. Most of the time, if we use the standardized allergen product, there is a very less severe adverse events. Because initially we have got the unstandardized product formulation, and the most of the patients, they were having a adverse events and poor adherence to the therapy. There are 33 allergens common in our practice, which we routinely do in our day-to-day practice. Among all these 33, house dust mite tops the list. 50% of the patients are positive with the house dust mite. If you have got 500 patients of the allergic rhinitis, 300 patients of the allergic asthma in the world, out of these 50% of the patients, they are sensitive to the house dust mite. If you include pollen along with the mites, the increase the sensitizations to even 67%. House dust mite, the two major allergen are the Dermatococci terrorismus, Dermatococci farini. It grows abundantly in the carpets, in pillows, in stuffed animals with a high humidity and the low temperature. If you intervene the environment, can the preventive strategy serve the purpose? No. Allergen immunotherapy, house dust mite needs always the allergen immunotherapy must be given if the patient is sensitized to house dust mite. There is a poor evidence that the avoidance measures are not sufficient to improve the asthma symptoms. So you need allergen immunotherapy with a house dust mite. There are many species of the dust mite, but the two groups are the common: Dermatococci terrorismus, Dermatococci farini. The rest of them, they are considered as a storage mite. These two species are responsible for 90% of the sensitization and allergic symptoms. Bolomia tropicalis is also has come with a allergenicity, but is restricted to some countries like Singapore. But in 90% of the countries, they are having the two species, the Dermatococci terrorismus, Dermatococci farini. These two species, 70% of the allergenic protein, they have got the structural similar homologous protein. That's why they are cross-reactive allergens in both of them. The life cycle is 10 weeks lifetime, and it excretes 2000 fecal particles during the lifetime. And it is the fecal particle which is responsible for the ongoing inflammation in our airways. These fecal particles has the peritropic membrane outside. This membrane contains the DERP23. And inside the fecal particles, there is a cysteine protease enzyme which is responsible for the ongoing inflammation and induces the allergenicity. We normally shake our pillows, carpets, and mattress once we go to the bed. During the shaking, these pellets, fecal particles, becomes airborne. Out of 100 fecal particles, 5 or 10 particles, they go into our small airways. And these are the fecal particles which is responsible for the ongoing inflammation in the small airways, inducing the nocturnal wheezing. If you have a 2 microgram of the dust mite, DERP1 in the house, it will produce sensitization. But more than 10 microgram of DERP1 per gram of the dust will induce severe symptoms. It has been found that those who are living in the coastal area, or even in the USA, it was found that the 50% of the house, they have got the house dust mite in the indoor. House dust mite has got a certain risk. Patients belongs to the atopic constitution to induce Ig antibodies. The most important is the early exposure of the house dust mite during the first 1000 days of the life. But that is the time when immune system is not fully developed. And the second is the persistent and a perpetual exposure of the house dust mite once we go to the bed. These constant exposure leads to the constant airway inflammation as well as the remodeling it induces. House dust mite, the common symptoms, this is a perennial throughout the year. Nocturnal symptoms most of the time, and most of the time the primarily predominant symptom is a nasal obstruction. Sleep disturbance is also very common, and these patients, they have got severe symptoms during the night time, and they have got a persistent loss of the lung function if patient is constantly exposed to the house dust mite. It induces not only the asthma, it also induces, along with the atopic dermatitis, aggravated, and also the another which has been found is the OMA, the oral mite anaphylaxis. These are the certain disease eliciting molecule, DERP1, DERF2, DERP2, and DERF2. DERP11 is the disease eliciting molecule for atopic dermatitis. Most of the patients of the house dust mite, they have got a comorbidities. Why this comorbidities is there? Because of the similar cytokines from the epithelial cells, IL-25, IL-33, TSLP, from the Th2 activation, IL-4, 5, and IL-13, they circulate in their system. Whether it is a conjunctivitis, whether it is atopic dermatitis, asthma, or it is a food allergy. These patients, they have got a recurrent respiratory infection because of the reduction in the interferon from the epithelial cells. 5 major allergens, DERP1, DERP2, DERF1, DERF2, and DERP23. These are the major allergens which are responsible for ongoing symptoms of allergic rhinitis and allergic asthma. There are 3 groups of the allergens in the house dust mite. The group A, which are the major allergens, and the group B, which are called the mid-tier allergens, and the group C are the cross-reactive allergens. These group 1 allergen, they are also called the immunodominant allergens. Group 1 cysteine protease presence, NPC2 presence, and from the body it is presence the other chitinase type. So these are allergens, they activate our innate immune system dysfunctional our innate as well as the dysfunctional our acquired immune system. That is the reason that house dust mite is a more powerful, more inflammatory major allergens in our system. It is the protease, cystine protease, which damage the epithelial cell binding, activate the IL-C2 or alarmins to induce these three cytokine IL-25, IL-33, TSL. It is the Th2 proliferations due to the house dust mite activations IL-4, 5, and 13. And it also cleaves the CD23, which is responsible for the excessive Ig production. And at the same time, it also decreases the interferon from the epithelial cell. Moreover, there are certain cytokines which also decrease the surfactant. So there is a reduction in the lung clearance. So house dust might disbalance our innate and acquired immune system. The major allergens, as we explained that, how to diagnose those. DERP1, DERF1, DERP2, DERF2, and DERP23. History is the most significant. Skin prick test, component result, CRD diagnosis, and nasal provocation test. Now, if you have a case of a perennial nocturnal symptoms, nasal obstructions, allergic rhinitis with a sleep disturbance, we do the skin prick test. This is a gold standard test. And the positivity is equivalent to the histamine, and moreover positive with the CRD, the component derived diagnosis. These patients need allergen immunotherapy. At the same time, there are certain group of the patient where the skin test is negative. It is doubtful whether the sensitization is in concordance with the clinical history. Here the CRD helpful for us whether to diagnose allergen immunotherapy. Now these patients also need allergen immunotherapy. While there are third group of the patients where the systemic IgE circulation is a negative, skin test is a positive, CRD component resolved diagnosis is also negative. These are the 30% of the patients of a allergic rhinitis. Now we define as a local allergic rhinitis, local allergic asthma. These patients, they need nasal provocation test. If nasal provocation test is positive, then they may need allergen immunotherapy. But if none of the three tests, skin prick test, CRD test, along with the nasal NPT negative, then we can say that this patient is a non-allergic rhinitis, non-allergic asthma. And then we have to select which patient should be given subcutaneous immunotherapy, which patients should be given sublingual immunotherapy. Because sublingual immunotherapy indicated those who are monosensitized. And it has to be given daily with a standardized allergen product. While the subcutaneous immunotherapy, once we have to make the updosing, here the injection is given every 4 to 6 weeks. So this in the consent with the parents, with the patients, then one has to choose which allergen immunotherapy is to be advised for a selective patients. Because sublingual immunotherapy is the therapy where the allergen is taken up by the APC. And it is the reason, is the vestibular reason, you have to give the tablet under the tongue. And from that, the APC will take up the allergens and then induce the immune response in our system. The tablet which is available is a lyophilized. This is tablet which is available. It is a FDA approved and it has got the two component of DERP1 and DERP2, while the another two component from the DERF1 and DERF2. Both are equally has been mixed in this tablet, and this tablet is now ready to take by sublingual immunotherapy. It contains the molecule, the 4 molecule, 7.5 microgram of the DERP1, 7.5 microgram of the DERP2, as equally of the DERP-F1 and DERP2. So total will come to 30 microgram, which is being given in a standardized tablets of SensiMune. Now this tablet has to be taken sublingually and it should stay there for 1 minute is the holding time. Guardian must confirm that the tablet has dissolved completely. After this, the tablet, once it is dissolved, then the waiting period is 5 minutes. No drinks to be taken after that. So there are certain instructions that this tablet, first tablet should be given at the physician office. It has proven efficacy. It is easy to administer. It is a cost effective and it is a highly manufacturing standard and a proven safety profile. This tablet has been used more than 9,000 patients as per the trials and 5 lakhs of the patients are on these tablets. This tablet has got a consistent efficacy among the children, among the adolescents, and among the adults. This tablet is unique. It ensures that the allergen composition and allergen release in the sublingual holding time is completely dissolved. Significant sustained reduction in the symptoms after 8 to 4 weeks is the treatment. Means within 2 months, the patients will have got a reduction in the symptoms of the allergic rhinitis as well as of the allergic asthma. This tablet has got the least adverse effect. Till today, there is no cases of the death, no cases of the anaphylactic shock, and less than 1% of the subjects has experienced with some adverse events. This tablet is for 3 years, daily tablet. Why 3 years? Because the first year, there is a decrease in the density of the Ig receptor sitting of the effector cells, mast cells, basophil cells, eosinophil cells. So during this first year, there is a marked reduction in the symptom. And the second year, there is a sustained effect. At that time, there is a synthesis of the immunoprotective cytokine, IL-10, TGF-beta, or the immunoprotective antibodies, IgG4 and IgA. And in the third year, there is a synthesis of the regulatory cell. The regulatory cells means that there is a tolerance now appearance with the Treg cell, Treg cells, ILC tolerant cells. Friends, for years and years, we have been prescribing this antihistamine, local nasal spray, local inhaled corticosteroids, with or without xanthine preparation, anti-leukotrienes, and biological. But these drugs does not have a long-term tolerance. These drugs cannot prevent the ongoing inflammation. We need etiological treatment. We need the treatment which will have got a long-term tolerance. We need treatment which can prevent the ongoing inflammation. And this treatment is that these patients, if you look at the Acrygex, it downregulates the inflammatory response as well as induces a switch from an allergic response to the tolerance building response. These patients should understand, these patients should know that they have got now the Treg cells, Breg cells, which will protect from the environmental insult. Normally what happens in our system, that if you have got a low dose exposure, it will produce the immunopathological cytokine. like IL-4, IL-5, IL-13. But if you have got a high dose allergen immunotherapy is a high dose which will induce the immunoprotective cytokine, which is IL-10, TGF-beta, or B-reg cells, IgG4, IgA, and even now some studies has come that it also increases the interferon gamma. So friends, mechanism is with us that these patients respond and these patients will induce FOXP3 CD25 Tregs. No question of efficacy with this house dust mite tablet once we have got a immunoregulatory system. But there is some contraindication. One should avoid in those patients, those who have got a multiple allergenicity, hypersensitivity reaction. FE1 is less than 70%, or if there is a history of the exacerbation in the last 3 months, or active autoimmune disease, acute respiratory infection, or there is some wounds or ulcer in the house, and concomitant beta block. These are the contraindication one should look before we start the tablet. Now let us look at the guidelines. What the guidelines says. This was the study done on 4,111 patients, the REJECT trial, which has confirmed that if you give as a add-on therapy of house dust mite tablet, it further prevents the ongoing inflammation, reduction in the symptoms from step 1 to step 2 or from step 3 to step 4. So this was the study done on which basis the GINA guidelines has recommended the use of consider house dust mite SENSIMUNE SLIT tablet in sensitized patients with allergic rhinitis or in FE1 more than 70% in a house dust mite driven asthma. But the tablet in 5 years and younger, still the evidence is not so strong. So we have to put our finger cross whether to start, but studies are going on. We are waiting for the studies. But in adult, after the 12 years, there is no question of efficacy, no question of the safety. In Yaki guidelines recommends that only the standardized allergen immunotherapy product should be used with the evidence of the efficacy in the clinical documentation. Means clinical history plus sensitization plus positivity of the major allergen plus the standardized product formulation. This is even the Yaki guideline says you have to differentiate whether your patient belongs to the house dust mite driven asthma or is it a asthma with a house dust mite sensitization. Means the patient is not having sensitization to the major allergen, but sensitization to the cross-reactive allergen. Then this therapy is not indicated. It is only indicated if you have got a atopic constitution or if the patient is positive to the component major allergens in the sensitization. So even the Yaki guidelines recommend that patients in a partially controlled asthma, you can add house dust mite tablet to facilitate achieve asthma control. But the condition is here that the FE1 more than 70% and there should be not any history of exacerbation for the last 3 months. So many trials are going on. 15 years robust clinical evidence we have, and we need more trials the children's till we prescribed in 5 to 11 years old. Now, regulatory procedures to extend pediatric allergic rhinitis indications to include children's age 5 to 10 years ongoing. So friends, in Europe, the studies done age 12 to 65 years in a patients, those where the VAS score was 5 means still they suffer in spite of having the proper and effective dose, the antihistamine and the nasal spray. And in asthma also, the age group is 18 to 65, that even after giving the ICS LAVA, The recommendation as an add-on therapy in asthma, not the sole therapy. So key conclusions, based on the largest development program for a house dust mite, the efficacy, no question. 25% reduction in the daily symptom score, 29% reduction in the daily medication score. No question on the safety. It is tablet can be given at a home administration. No need of any up dosing is required. And this tablet dissolved within 15 seconds within the sublingual holding time. And onset of the symptoms starts in 8 to 14 weeks. So I think from our practice will change if we have a add-on therapy, if the patient is sensitized to house dust mite, with a clear-cut finding by the golden test of the skin prick test, along with the component resolved diagnosis. With this, I end my talk. Thank you very much for your kind attention. Thanks, sir.